Good morning and a warm welcome to all. At the outset, I'd like to thank the Ophthalmic Society for this opportunity. My topic is on hospital infection control. News like this are becoming more and more common, and it is not a crime to have an endophthalmic practice. But if that has occurred because of not following certain basic protocols, then it is viewed seriously in the court of law. The main intent of this talk is to help healthcare organizations formulate an effective hospital infection control program, implement it through a committee, and also help the hospitals in staff education. These are the broad headings under which I'm going to base my talk upon. The first and the foremost part in hospital infection control program should do is to assessment of the infection and the sources of infection. The infection source could be from person to person, clothing, environmental contamination, airborne contamination as in the present pandemic, and hospital staff carriers. One important point to note is the rare common source of outbreak, which is unique to ophthalmic practice because we use multi-dose while it is used among multiple patients, starting from the balanced salt solution to intercameral and intravenous antibiotics. So this has to be kept in mind while assessing the source of infection. Once the infection is assessed, while giving an antibiotic, the hospital should have a proper hospital antibiotic policy, which is based on some scientific study. And the hospital should ensure that all the doctors of the hospital follow this antibiotic policy. The use of personal protection devices need not be overemphasized, as an whooping 74.4% of healthcare workers getting infected because of not using PPDs or faulty PPDs. So it is the duty of the hospital administration to ensure the right quality, right quantity, right time, and justified use of proper PPD based on the Ministry of Health and Family Welfare. In the time of COVID, the PPDs in the OPD and the OT are almost the same. Hand wash, important, we overemphasize. There are 3 different types of hand wash, which differs in the timing and the materials used. It is always a good practice to wash your hands and your feet before you go into any high-risk areas, especially the ophthalmic theater. The timing of hand wash are the 5 timings which are usually noted by WHO, which is before you come in contact with the patient, after you come in contact with the patient, after you perform an aseptic task, or you come in contact with the blood and body fluids. Environmental cleanliness. The role of environmental pathogens transferring the infection to patients is very clearly defined. The most difficult part is that it is very difficult to keep every surface in the hospital clean all the time. Hence, staff education is very important to clean all these areas which the patient comes across. However, there are certain areas in the hospitals which are which are more prone for infection, especially the interiors of the refrigerator, the hand handling units. So special care has to be taken to clean these areas periodically, and proper surveillance has to be done. The other most important source of infection in any hospital is the water. As water is used for different disinfecting process, it is a good policy that the hospital always takes care of the quality of the water, and also does a routine microbiological surveillance at least twice a month for the water used in the hospitals. In the case of blood and body fluid spillage, every staff should be taught about the proper usage of the spillage kit, and after using the spillage kit, they have to be disposed as per the biomedical waste disposal norms. The cleaning schedule, especially for high-risk areas, is good to follow the 3-bucket technique, where a clean and dry mop is immersed sequentially, and the figure of 8 mode of cleaning is used. This is a tabular column which shows the different frequency where a high-risk area has to be cleaned. The 1% sodium hypochlorite is the most inexpensive and effective way of cleaning the surfaces. This tabular column shows you the different ways in which a 1% sodium hypochlorite can be prepared. So in a HVAC system theater, before entering the theater, make sure that the cooling component of the HE is on and the physical parameters are attained before you enter. And once you enter, all the medical and non-medical surfaces are cleaned with an alcohol a base non-hydride-free disinfectant, and make sure you use a different side of a lint-free cloth to clean them. And once this is done, the surgical load is brought into the theater. The first and the foremost thing an assisting nurse should do is to inspect all the indicators and ensure that the tape selection process has been effective. After this, the Mayo table is prepared wearing proper PPD devices. A small note on the storage of the medicines. These should be stored as per the manufacturer's guidelines, and it's important the physical parameters are noted down 24/7, especially in the storage areas. The other place where we store the surgical instruments are the safest area. Even here, the physical parameters have to be monitored regularly. In case you don't have a HVAC system installed in the safest area, you can use a data logger to record the temperature and physical parameters 24/7. Engineering control is basically a strategy where there's a barrier between the healthcare worker and the hazardous condition or the pathogen. A simple example would be to installing an exhaust fan which pumps in all the stale air out of the room, and a more advanced one would be the HVAC system, which is going to clean, purify, and make the air bacteriologically free before it comes to the theater. So in the hierarchy of infection control measures, the engineering control comes in the middle of the pyramid, just above the administrative control. To give you a small highlight of what the HVAC system looks like, it consists of three parts: the air handling unit, the compressor, and the laminar airflow. The interior of the air handling unit consists of three chambers with two sets of pre-filters and a blower which cools the air and makes it flow into the theater through the laminar airflow system, which is nothing but a unidirectional flow of air from the ceiling across the room through the table into the return air ducts back into the AHU. The disinfectant and sterilization process, the backbone of any surgical unit. So this is the circle or the 6 stages of instrument sterilization. After usage or after it is procured, it is cleaned, disinfected, inspected for any breakage. If it is broken or not usable, it is disposed as per biomedical waste disposal norm or returned back to the manufacturer. Then it is packed, sterilized, and stored for further use or back into the theater to be used. A small note that I would like to highlight here is that all surgical instruments should be sterilized as per the instruction for use given by the manufacturer. See, once the instruments are used, they have to leave the theater immediately, and it is not a good practice to keep the used instruments inside the theater while the other cases have been operated. Once the instrument reaches the central sterile supply department, they are cleaned under running warm water, and they are cleaned sequentially using the 3-bin technique. And after, maybe before, they can also be processed using an ultrasonic cleaner before they are processed using the 3-bin technique. Then the instruments are allowed to air dry. In case you want to use the instruments immediately, you can use a high flow air gun, which helps you to remove the moisture immediately, especially in hollow instruments. Now the air dried instruments can be packed either through a traditional linen or through a non-woven paper, the plastic paper pouches, and the thickness has indicated here. A small note while packing is that the instruments has to be packed individually, and they has to be packed allowing room between these trays so that it could allow steam to percolate inside. And it's also good practice to place all the trays vertically for proper penetration of the steam into the instrument trays. A small note on the different kinds of steam autoclaves. We all know that the steam autoclaves are the widely used worldwide. Depending on the type of air removal from these autoclaves, they're classified into the gravity, pre-vacuum, and the pulse pressure. In gravity autoclave, there is no active way of the air being removed. As you pack the autoclave with the material, the air gets displaced. However, certain amount of air pockets remain, which could act as a barrier for steam sterilization or steam to go through there. As a result, hollow instruments are not properly sterilized in the gravity autoclave. The pre-vacuum autoclave, there's an active air removal where there's a vacuum pump which is on before the sterilization and after the sterilization. This just happened once, but however, the class B or the pulse pressure steam autoclave, there are multiple cycles of pressure and steam to remove the air and is more effective. The pre-vacuum and the pulse pressure steam autoclaves are ideal for ophthalmic use. Once the sterilization is being done, the quality assurance sterilization is done using physical indicators, chemical indicators, and biological indicators. So the different kinds of indicators start from class 1 to class 6. So a small note on the biological indicator in terms of 2 vials. 1 vial is actually sterilized, and after it comes out, the control and the vials are processed after the inner tube is broken. The vial which is processed inside the autoclave does not turn in yellow in color, but the controls turns yellow in color. The biological indicator has to be used for every load in every cycle. The class 5 indicator is equivalent to the biological indicator, and once the chemical indicator inside a class 5 crosses the center stage, then it can be used. The manufacturer guidelines indicate that once the indicator crosses the center, it can be used. So this is the perfect look of the class 5 indicator. So this is the tabular column of what kind of indicators has to be used in different cycles. The OT microbiological survey is also important. It can be done regularly. It can be done through air sampling, water culture, biological indicator, particulate count, indicator of HVAC control, and effectiveness of housekeeping also. The biomedical waste disposal norms are quite stringent now, and the success of any surgical unit depends upon the proper biomedical waste disposal. Segregating a source is quite important. The needles have to be broken and packed separately, and the different classes of the biomedical waste has to be measured before it is disposed. Water disposal chambers are also important, and the water has to be treated before it is let into a sewer. Ophthalmic practice uses different consumables which are reused. Hence, a policy should exist on a number of times a particular instrument can be reused. And in the event of a sterilization failure, there should be a process to recall the instruments as well as the as well as the patients on whom these instruments has been used. Pre and post prophylaxis expansion is quite important, especially for hepatitis B. And finally, staff educating the crucial roles in hospital infection control program. Quality indicators can be defined as per use. Of the examples for quality indicators are listed here.